And with that, we'll now begin our Q&A session. Just a reminder, you can simply type your question into the chat box below the video frame if you would like to submit a question. And I also want to acknowledge Dr. Garcia is joined by several fellow committee members to help answer your questions. As she said earlier, we are joined by Mr. Alex Capron, who is the chair of this committee and a professor at the University of Southern California, where he teaches public health law and policy, bioethics, and torts. We also have with us today Dr. Adolfo Garcia-Sastre, who is Director of Global Health and Emerging Pathogens and Professor of Microbiology and Medicine at the Icahn School of Medicine at Mount Sinai. We have Dr. Raina MacIntyre, who is Professor of Global Biosecurity, a National Health and Medical Research Council Principal Research Fellow, and Head of the Biosecurity Program at the Kirby Institute in Australia. We have Dr. Linsey Marr, who is Charles P. Lunsford Professor of Civil and Environmental Engineering at Virginia Tech. We have Mr. Tolbert Nyenswah, who is a Senior Research Associate with the Department of International Health at the Johns Hopkins Bloomberg School of Public Health. We have Dr. Rosanna Peeling, Professor and Chair of Diagnostics Research at the London School of Hygiene and Tropical Medicine and Director of the International Diagnostics Center. And we have Dr. Marybeth Sexton, who's Assistant Professor of Infectious Diseases at the Emory University School of Medicine and Medical Director of Antimicrobial Stewardship at Emory University Hospital and epidemiologist at Emory Clinic. And with that, again, we will start the Q&A. We do have a first question for you all, which is, why did the committee recommend against physical barriers?
So I would like to invite Linsey to answer that question.
We see these types of barriers everywhere, but there's extremely limited evidence to show that they work. And they are, and face shields are really barriers intended to block spray by large droplets. And they actually would not work for aerosols in the same way. We did find limited evidence that they can potentially be harmful. For example, there was a study of schools where they found that there was an association between the use of plastic barriers on desks and a higher incidence of COVID-19 symptoms. There was also a study. There has been a newer study showing that the barrier does reduce exposure to aerosols in a situation where you have two people directly across from each other for a brief period of time, but it doesn't account for increased exposure to people who are on the same side of the barrier or someone who might come in right afterward. They can block proper ventilation of the space, which is critical for removing aerosols, and thus we recommended against them.
Thank you. Our next question for you all is, can you clarify the circumstances when countries should be allowed by the international health regulations to close their borders during a pandemic?
Raina?
Yeah, that's an interesting question. And I think the origin of that recommendation in the international health regulations and the recommendation of WHO not to close the borders is more around concern about trade than around health. And in the end, closing the border is a national decision. And countries that did use that strategy, ranging from Australia and New Zealand to small island nations with very weak health systems like Samoa, managed the pandemic very well last year with maintaining essentially a zero or minimal COVID scenario. And economic studies subsequently have shown that that was actually more beneficial, both economically and health-wise.
May I add a word about that? I think it's important to understand that the use of such a limitation at the border or complete closure at the border depends upon the nation not already having community transmission of the virus. It's not an effective strategy otherwise. So it's a relatively limited situation. Moreover, we were sensitive and discussed the reason for that being part of the IHR, this general prohibition on using border controls. And that is, it's important that nations not be discouraged from quickly reporting outbreaks that could become pandemic, to allow other processes to kick in and decide what the global response should be. And so it's important that when they do that they not be singled out. And there were experiences, obviously, with COVID of focusing on that process of singling out, and it was very unfortunate. So therefore, it's important that this notion of closing is in circumstances where it would be possible to allow the country to have much better control because it isn't already subject, and the closures are global. They're not directed at the country that made the report. And with that, we thought the reasonable balance was to have the IHR adjusted to recognize that there will be circumstances where that is a good public health countermeasure.
Thank you. And as a follow-on to that, doesn't the recommendation that the international health regulations be amended to allow countries to close their borders run contrary to the recommendation to eliminate disincentives for countries to report outbreaks of pathogens with pandemic potential?
Well, Stephanie, as I tried to suggest, we think that would not be the case, that there would be a contradiction between those. We think it's very important that incentives exist at the local, regional, national level in making reports, including that final level between the nation and the global institutions. And you can avoid that if any response by closing borders does not single out that reporting country, but rather, or countries, but rather is instituted at a time when the country wanting to make that limitation could have a very substantial benefit, and it is doing it worldwide, recognizing, as was certainly true in COVID, that the spread of the virus, the respiratory virus, is likely to be wider than whatever is perceived at that moment. And so they have to be very certain that they're in a situation where they're not having community transmission, in which case the border closure would be ineffectual and set a bad precedent, and that they are doing it as to the rest of the world rather than as to a country that has done the responsible act of quickly reporting an outbreak of a novel virus that could have pandemic potential.
Thank you. Our next question for the committee is, could you please explain more about what role you are recommending for the World Health Organization in getting countries to adopt standards for ventilation that would be more protective of people indoors?
Linsey?
We are asking the World Health Organization to develop guidelines for ventilation. There is some material out there now. I think there's a lot we've learned and a lot that can be done to further emphasize ventilation and provide some numerical targets for ventilation rates that will appreciably reduce the risk of disease, of transmission.
Thank you. Our next question is, In recommendation for point 2, you mentioned leaders should model good behavior. Did the committee talk about what to do to mitigate the impact of that behavior?
Anybody that would like to answer that? One of the things that we realized is that by the time we were starting to work on this report, okay, which has to be based also on evidence, most of the evidence was just being collected, and most of the studies that had to do with the leadership and the context were starting to be done. People, even researchers, have been very busy trying to fight COVID. So this is an area that definitely needs more data, needs more research. We need to learn, and that's why we were highlighting also the importance of doing research, behavioral research, social sciences, to try to understand how to better work together and how politicians, the community, leaders, how their behavior could potentially be critical on how the populations will take the interventions. Legitimacy and trust are two issues that are critical in this area.
You know, a related aspect of that, Patty, that I think you mentioned, and very important, is allowing the recommendations, which must be based on the current evidence, to reflect changes in the evidence without undermining trust. And this is an extremely, we talked about this, is an extremely sensitive matter. And having that consistency by the leadership, the political leadership, which is not in a position to make the judgments necessarily in the first instance about the evidence, which is an expert matter, reflecting when those judgments need to be made, reflecting what the evidence shows. And, you know, the old saying, when people say, do what I say, not what I do, we say that as a joke because we recognize it's very hard to have trust in a recommendation that the recommender isn't following. And so ideally, as was exhibited in some countries very well, the political leadership communicates to the public that we're making changes, not in an arbitrary way, but because we now have evidence. The evidence, for example, on the effectiveness of face masks developed in the early period of the pandemic, and it required a different message. Not masks are not a primary tool, but masks are a primary tool, along with several of the other countermeasures. And that understanding developed. And so the role of the political leaders is to overcome people's skepticism when recommendations change and to communicate we're changing because we know more now than we did last month or last year. And there is a solid reason for changing, and I'm going to follow that. I'm going to put on the mask. I'm going to socially distance. I'm going to avoid indoor meetings and so forth. Having crowds of people come to indoor events, that's not the time for that. And I'll show that in my own behavior. And without that, it's very hard for the scientists who are carrying out the studies, making the interpretations, to have full understanding of the public. Because of course, when things change, there's a natural inclination to think people are being inconsistent. No, they're being consistent with new evidence. And that's what we were trying to emphasize in that recommendation.
Thank you. Our next question is, the report mentions Global Health Security Index preparedness scores did not always accurately predict pandemic response. How much weight should we give to this finding? Does the report offer advice on how we can define preparedness, or should that be adjusted?
Marybeth, would you like to answer that?
Sure. So we looked at, with respect to defining preparedness, looking at that particularly from the therapeutic and allocation of therapeutic perspective. And so in recommendation 5.2, we laid out that list of ideas that should be addressed ahead of time and then adjusted as needed. But things like, how are you going to make decisions about which guidance you're going to follow? How are you going to make decisions about who is prioritized? How do you assess your supply chain ahead of time? And then how do you execute on your supply chain in the moment? How do you ensure that that is all done equitably? And so that degree of preparedness, I think we really learned from COVID, is critical. And I think will have a lot to do with how we attack an influenza pandemic in the future, because a lot of those issues will be the same about how to allocate therapeutics, where to allocate therapeutics, and what the supply chain looks like and what to do when it's disrupted. So I think with respect to existing scores of preparedness, it's not that those should be disregarded, because they contain a lot of other inputs into how those are calculated that go beyond some of the preparedness aspects we addressed with respect to non-vaccine interventions, and including into the vaccine realm, which some of the other study groups have addressed. But I think it's important to remember that as good as some of those indicators can look, how you're going to be able to shift depending on the pathogen, the mortality rate, the transmission modality, and how contagious something is, that your ability to pivot in the moment and to address some of those challenges, and your ability to address a supply chain that globally may be impacted, may not be picked up as well in existing metrics, and are things that we need to be able to prepare for in advance.
I might just add to that probably, I think all the indices that go into something like the Global Health Security Index are good and necessary, but looking at lessons from the COVID pandemic, the three things that probably weren't accounted for that should be accounted for in subsequent iterations of such indices are culture, leadership, and universal healthcare. And those three things could explain, for example, why relatively affluent countries did badly last year.
We also noted other social factors very much related to what Dr. MacIntyre just said, which is if there are equity issues in the implementation, that certain parts of the population will face particular difficulties in following the recommendations. If housing is insecure or food is insecure, if there's a lack of replacement income and so forth, you have equity issues in trying to achieve people distancing, staying at home, and so forth during the early spread of an pandemic. And we therefore noted that as a barrier to implementation. And unfortunately, those kinds of disparities exist in high-income countries as well as low-income countries. And so we saw a good deal of that. Does any other member of the panel want to comment on any of the other failures of the predictive scores?
Well, I think we all agree that the predictive score didn't work because there are other aspects that we have just realized that are important. But even with the predictive score, several countries had a very low score and nothing was done. So it's not enough to have this scoring, but we need to think globally. How do we approach and how do we help countries, or how do we as countries really take the responsibility of changing those issues? So I have to say that, I know about several Latin American countries doing this questionnaire is voluntary, and we knew what were our weaknesses, but nobody, especially at the political level, this was not a priority. There are priorities that are fighting between each other, but I think for this might be the moment right now, when we still have fresh what is going on with COVID, to think it's not only measuring, but what are we going to do with those measures? So with those numbers, what are the kind of things that need to change and how to improve?
So I want to jump in a little bit on the index score and all of that. And for full disclosure, I'm a member of the panel of experts on the index. And so I know we done a lot of adjustment on some of those things that Raina and Patty have mentioned concerning especially political leadership, the importance of that, and cultural issues, social determinants of health, and all of those things have been taken care of right now. By December, another report is coming up very shortly that incorporate all of those issues. Thank you.
And I just like to add that I think through this pandemic, we've learned that public health, unlike what we thought we used to do well in public health, we need the public to be part of public health. We cannot simply just tell them what to do and they will do it. So I think with this pandemic, we've learned that, no one's safe until we're all safe, and that we need to give the public the tools, the data, the knowledge in order to act responsibly. And that is something that we should think about for the Global Health Security Index for countries, how much they can establish what John Nkengasong, the head of Africa CDC, said should be the new public health order.
I might just add to that the issue of culture, that public health measures for epidemic control or pandemic control are necessarily draconian because you have to stop people contacting each other. And whether it's face masks, which, there was no culture of face mask wearing in Western countries, or movement restrictions or density limits or lockdowns, countries that have a very highly individualistic culture, it'll be much more difficult to implement those sort of measures. Whereas countries that have a more collective culture would have greater ease in implementing those kind of measures. So I think those are some of the culture is really important. And then universal healthcare, if you've got to pay for a COVID test, and we know how important testing and identifying cases is, you're not going to get good rates of testing. It's got to be free and easily accessible.
Thank you. Our next question is a two-part question about diagnostics and therapeutics. So the first part of that is, does the report address specific recommendations about therapeutics for influenza, any potential future research priorities? And then the second part is, would we ask everyone to get tested for the flu as we did for COVID-19, or would we not recommend everyone get tested if they have flu-like symptoms?
Rosanna, would you like to take the lead on that one?
Okay, so I think for testing, for our report, we didn't find enough evidence to say whether we should do more testing for flu and less testing for COVID, or the other way around. First of all, COVID is a new pathogen. So that's why at the beginning of the pandemic, the Director General of WHO said, test, because we need to do all the testing we can to know how the pathogen infects people, what are the common clinical syndromes, so that we could refine the clinical definition of a case. And also we want to identify cases early, be able to do contact tracing and stop the spread. So that is why we have testing centers. We urge everybody who has COVID-like symptoms to get tested. But I think as we know now more about the pathogen, we know its way of transmission, and we're more able to control the disease, especially with vaccines, then we are looking to see whether this virus would become endemic. And once it's endemic, then it would be very important to start adding COVID to the surveillance that we have in countries. And then, I think that at that stage, when COVID becomes endemic, and it's just all a part of a seasonal cause of respiratory infections, then countries may be better, able to use their resources to do strengthen surveillance and track emergence of variants of concern, etc. And so right now it's too early to tell one way or the other. So the story is to be continued.
And maybe I can add something about therapeutics. For influenza, we have some drugs available. We have neuraminidase inhibitors, we have an endonuclease inhibitor, but these drugs, they need to be taken very early on during infection in order to make an impact. They make also an impact for people that are hospitalized, but the impact is more limited there. And we know very little about how to treat severe disease, which is also one of the issues that we found with COVID-19. The use of dexamethasone, the use of anticoagulants, they seem to help some individuals, but not all the individuals. So there is still a lot to be learned about how to treat severe disease for both COVID-19 and influenza. And there is also the issue of potentially resistance to already existing antivirals for influenza, and therefore the need for more broad spectrum antivirals for influenza that may not lead to development of resistance. But especially in the area of treating the host according to symptoms, there is certainly a lot of things that need to be done still, and we know that both from COVID-19 and for what we have already available for influenza, we need to do quite research on that, and it's clear.
And I think along those lines, one of the things that we tried to call attention to in the report is that more than direct transition of therapeutics for COVID-19 to influenza, because we know that some of those do not cross, that some of the guiding principles of therapeutic research that we learned, to Adolfo's point, to focus on during COVID-19 may have applicability to influenza. So things along the lines of going after some of the host inflammatory response to disease, and how does that apply to severe disease with influenza? Things like dexamethasone, tocilizumab, baricitinib that we've used with COVID-19. Are there similar avenues to address with influenza? And so looking at some of those areas of crossover on the general principles of the research on therapeutics.
Thank you all. And I know we're coming up on the hour, so this question will be our final one. And it's like you stated in the study, lab studies, randomized controlled trials, and observational studies demonstrate that face masks are effective for both COVID-19 and influenza. However, as has been seen in the US, especially, some of the best measures for protection have been highly politicized. How do we reverse this and communicate to the general population that mask wearing may be here to stay?
That's exactly what we are trying to introduce in chapter 4 when we are talking about the context, okay? So those measures that depend on the behavior of humans need more research to understand why humans act the way they do. So one of the calls is we need really to do more research, social sciences and behavioral research, to understand how to change those behaviors, how to better communicate. Alex was talking also about having the models, the leaders that could become role models for the use of these measures. I think disseminating better the information that we have right now is not going to be enough. Okay, we know from the history of HIV and other diseases, I mean, we know that condoms work, but people don't use condoms, okay? So we still, I think there is a lot that needs to be there, but having right now the scientific evidence is the first step. We need to work also on how to communicate that better, but we need to understand how to better act on the behavior of people. changing of the behavior is very difficult. Cultural norms, as Raina was saying, I mean, for societies that are more individualistic, is more difficult. For us, people are using masks, but the problem is that they don't. And I'm talking about Latin America. We're very social. We don't respect distance, social distance. We want to be very close together, right? So these kind of issues need to take into account. So it's not enough to have effective measurements. We need to understand how to implement it better. And for that, we need all the sciences working together.
In that light, this is where the bottom-up approach is very, very much critical, engaging the community.
Yeah.
Thank you.
Well, thank you all. Thank you to Dr. Garcia and to all of our committee members who participated during the Q&A and for very thorough discussion on the Public Health Interventions report.